We are getting the latest in COVID-19, and joining me now is Dr. Malathi Srinivasan from Stanford Health Care. Thank you so much for being here today.
It's great to be here. Thanks for having me.
So we're going to get started here. So how does this round of increased cases and hospitalizations compare to those in the past? And we're talking about increased cases in COVID and hospitalizations this like past year. It just seems like it never ends.
Right. So we are in the middle of a never-ending pandemic. The COVID virus is now endemic, means it's here for life and it's going to be with us for generations. But the thing to know is that of the COVID-19 variants, the Omicron BA.5 is the most transmissible and the best at evading our immune protections and our vaccine protections. And over the past few weeks, we've begun to see a wave of hospitalizations. Now, hospitalizations are up 20% and deaths are up about 10% in comparison with a couple of weeks ago. And so we're having about 400 people a day dying from COVID, which is a pretty significant number. I mean, to keep it in perspective, it is a lot less, over half less than the massive hospitalizations that we were seeing in 2020 and 2021 before vaccinations and oral treatments were available. And as you know, the current vaccines were developed against the original strain of COVID-19, and they were about 95% effective at preventing hospitalization against Delta, and about 80% or so against BA1 and BA2, which were a lot more mild than BA5, but they're less effective against BA5. So we don't really have the numbers, but we're probably handicap at around 60% at preventing hospitalization, and certainly much better at preventing death. So we're still getting protection against severe disease, but not as much as we would like.
Yeah, and so that comes to my next question. So a second booster could soon be available to everyone. How will this affect the recent surge, and why is it not available any sooner?
Right. So we hope that by fall, we'll have vaccines against COVID strains BA4 and BA5. They're very similar, especially because the White House coronavirus coordinators, Ashish Jha and Anthony Fauci, have really endorsed a quick release. Now, the COVID-19 vaccines have been absolutely life-saving for millions of people. We've seen a massive reduction in deaths, especially for people who are older 50 or with any comorbid conditions, like diabetes or obesity, kidney disease, hypertension, immunosuppression. But here's the big question. In fall, what will be our dominant COVID-19 strain? So unlike the DNA viruses, which are a lot more stable, the RNA viruses tend to mutate pretty quickly. And so if we get a vaccine in fall against BA5, will that still be the circulating strain? And will the circulating strain be close enough to BA5 to offer substantial protection from both hospitalization and death? And I think that's an open question. So, people have asked, why is it taking so long, right? Why don't we have a better vaccine? And we really don't have any clear answers. There's probably a combination of factors. I think initially the drug companies like Moderna and Pfizer, which are the ones that are really able to respond very quickly because the mRNA vaccine lets you grow up the vaccine very quickly. They were deciding what strain to use. And now the government has given very clear instructions that they're asking them to focus on BA4 and BA5. So after that, you've got to have trials to demonstrate that the vaccines are effective. And I think the vaccine manufacturer are also seeing a decreased sense of urgency about getting the vaccines out. As you may know, in the US, only 67% of people have been vaccinated, and only 34% have had their first booster. Now, in the Bay Area, those numbers are much higher, but nationally, we still have a long way to go. Now, when Pfizer and Moderna had first developed this new technology, which has been developed over about 20 years, we knew that they could develop a new vaccine within 6 weeks and really kind of scale and distribute it within about 100 days. And it was only 300 days from the original genetic sequence of COVID being available to getting emergency use authorization by the FDA. We've never seen drug development that fast before. So we're hoping that now that we have identified which strains to use, the manufacturers are going to be able to have that rapid technology put to good use and be able to get us some good vaccines in a couple months.
So we've heard of reinfections, which is more common with this variant. So Why is that? And are the symptoms any different?
Yeah, so Omicron, BA4, and BA5 are two most catchy and immune evading COVID variants to date. And the nature of the mRNA vaccines is to mutate. And the BA5 has significant mutations of the spike protein, which lets it attach to the cell better using the ACE2 receptors. And it's got other mutations in other parts of the virus too. So those mutations make it less recognizable to our vaccines and our immune system, and to the people who've been previously infected with COVID. Now, from a pathology perspective, this is really the worst version of the virus yet, just based on hamster models and looking at cell cultures of lung cells. Now, this virus is considered more fit when you look at fitness testing in terms of how fast it grows, how well it evades the immune system, and how fast it spreads. And there's also things that you can look at like antigenic and distance maps, and you get a real sense about how different this virus is from the original strains. And if you take a look at the serum of most people who have had BA5, they don't have as much of the neutralizing antibodies that let you clear out the virus as quickly as the other ones. So in the real world, though, we haven't seen that massive rise in hospitalizations that everybody was fearful would happen at the beginning of summer. And that's for two reasons. The first is that we still have partial protection from the immunization boosters that was done with the original vaccines. And second, a lot of people who were infected with BA1 and BA2, which causes a much milder illness in general than BA5, those people have enough similarities in the antibodies and their cell response that they were able to mitigate the response to BA5 because their immune system was a little bit more ready for it. Now, the symptoms are pretty similar to all of the other COVID strains. So, pretty significant fevers and chills, just those terrible muscle aches and bone aches, significant fatigue, headaches, and loss of smell and taste. We don't know if BA5 is going to cause more long COVID than the other viruses, and we're hoping that it doesn't, but I think only time will tell.
Yeah, only time can definitely tell. So some people that test positive for COVID can be prescribed Paxalid, but we're hearing about the Paxalid rebound effect. Can you kind of explain what that is exactly?
Sure. So Paxalid is an oral antiviral that's a combination of two antivirals, ritonavir and nirmatrelvir. Now, it reduces hospitalizations from COVID by about 90% for people who are higher risk, and it works by blocking an enzyme that allows the virus to replicate. So for most people with a normal immune system, it takes about about 4 or 5 days before the viral levels are suppressed enough and your immune system can clear it out. So it needs to be taken within 5 days of symptom onset, and you usually take it twice a day for 5 days. So Paxlovid basically keeps the viral levels low while your immune system gears up and fights the infection and clears it out. And what we hope is that Paxlovid and the other antivirals will also protect against long COVID by keeping those viral levels down and not triggering the immune system so much. But most people, again, who get COVID will probably clear it out within about 5 days with the help of Paxlovid. But what we're seeing is about 1 to 2% of the people who are taking Paxlovid have their symptoms improve, their antigen testing negative, and then about 3 to 7 days after they stop taking Paxlovid, their symptoms recur and the virus is rebounded. But here's the thing, it's not actually a viral rebound. The good news is this does not seem to be from drug resistance. So the virus hasn't mutated in a way that the drug's not effective anymore. Instead, a couple things might be happening. The first is that some people might metabolize this drug faster, or some people's immune systems may not respond aggressively enough to clear out the virus in 5 days. So the people who are fast metabolizers would need a higher dose to get the same blood and tissue levels as the average person. And people whose immune systems are affected and may not be as robust might need a longer course, maybe even a couple of weeks. And we don't have the testing to figure out who those 1 to 2% of people are who may be fast metabolizers. Certainly for people who are sicker, they may need a longer course. So if you are in the 1 to 2% of people who get a Paxlovid rebound, first contact your doctor to ask about other treatments for COVID, because there are a bunch of other antivirals available, including high-dose monoclonal antibodies and remdesivir and other types of medications. And then please wear a mask and continue to socially distance until your symptoms improve and you're antigen negative.
All right, Dr. Malathi Srinivasan, thank you so much for being here today.
Well, it's my pleasure. It's great to see you.